Some of this we've covered. Some of it will be a review. Some of it is just going a little more in depth on the stuff that we've already covered. So how do we know that a person needs PAP? We need to establish the diagnosis first. Like, this seems so commonsensical. Like, why do I have this at the very beginning? But there's been plenty of times that, I've gotten test questions back and it's like, you almost overthink the test questions or something. We need that diagnosis of OSA before we can go ahead and institute PAP therapy.
So the types of respiratory events that PAP can treat are all listed here. I'm not going to go through and explain each and every one of them. We just talked about all that in the previous lecture. But just a quick review. Sleep apnea is when the airways do collapse on themselves, caused by the relaxation of the soft tissues and muscles in your throat and mouth. Apnea is when you have that complete blockage. Hypopnea would be a partial blockage where some airflow is getting through, just not enough to maintain the body's ventilation needs, causing that oxygenation drop. And then snoring would be where there's that partial blockage, causing a vibration of the soft tissue, causing that crazy noise of during inhalation and exhalation, mainly during inhalation. But CPAP.
CPAP is generally recommended if a person has an AHI of 15 or greater, which means that their apnea is in the moderate range. Or if their AHI is greater than 5, but they are symptomatic. Okay? CPAP is generally recommended for any patient with an AHI of 15 or greater, regardless of what their symptoms are, or regardless of whether or not they even feel like they have symptoms. But it's also recommended for people on the very mild end of the spectrum, because you'll see plenty of patients that come in and they've got like an AHI of 7, and the tech might comment, well, why are we putting CPAP on this person? Come on, really? But if the patient is symptomatic, why not try to improve their complaints? Why not try it? So that's if patients are complaining of tiredness, insomnia, and inability to breathe or sleep. It's impacting their ability to think, their mood, if they're comorbidities, hypertensive, ischemic heart disease, stroke, CHF. Again, it all comes back down to what the clinical picture is for when you treat. So the most effective non-surgical treatment for OSA is CPAP. It's the first treatment of choice and the most widely used. Because the only way to cure apnea would be with surgery. The only surgery that is 100% effective is, there's one surgery that is 100% effective in curing OSA, trach. Let's bypass the upper airway altogether. And beyond that, surgeries are not 100%. They are not. And when somebody undergoes surgery, it doesn't mean that they still don't have apnea. It just might mean that their apnea is less severe. So this is why CPAP is the first treatment of choice. And it's a treatment. It's not a cure. One of the things I always stress to our patients is that as soon as you go to sleep without this, your apnea returns, which is why it's so important that you use it night after night. Just like a pill. A pill is a treatment. It's not a cure. As soon as you stop taking the pill, it's going to stop having its therapeutic effect. Same thing with CPAP. How it works is it delivers a continuous flow of pressurized air into the airway. And it creates this kind of positive pressure that acts as a stent that just holds the airway open. So when our airway would normally be fairly floppy and collapsible when we fall asleep, instead this pressurized air comes into the airway and just holds it open. So one of the things that I explain to the patients is it's not breathing for you. It's not stimulating your breath. It's not forcing you to breathe. It's just holding your airway open so that when you fall asleep and those muscles relax, you can keep breathing normally. Get the difference? So the machine delivers room air. It's not oxygenated. I always say that to the patients as well. It's exactly what you're breathing now, just delivered at a constant pressure. And the pressure generally ranges, our machines go anywhere from 4 to 20 centimeters of water pressure. And for the person to receive that air, they must breathe through a mask that fits snugly against their nose or their mouth or in their nostrils. And how CPAP works is it acts like a mechanical splint to keep the airway open. It maintains the patency or the openness of the airway, especially in the vulnerable portions of the airway. Thereby, the patient is able to breathe normally and exhale normally without having those changes in their airway, creating the apneas and the hypopneas that would be waking themselves up. With CPAP, OSA can be eliminated completely or at the very least be improved upon so that the person's finally able to get a quality of sleep. But it's not a cure. Every single time they go to sleep without it, the apnea returns. So I recommend even if you're taking a nap, wear the mask. Pretty much whatever a person gains by wearing CPAP, whatever they gain in terms of how they're feeling and all of that, can quickly turn around and deteriorate when they stop using the CPAP. You know, again, it's not accumulation effect where, okay, I used it for 5 nights, I'm good for the next 2. Doesn't work that way. On the counter to that, though, you will see that, you know, say a patient's coming in for a repeat baseline and they're on CPAP at home, the physician might request that they go without CPAP for the night or 2 prior coming into the sleep test to just have a really accurate look at how their sleep is, so that way they're coming in a little bit more sleep deprived if they're waking themselves up more, to get a more accurate look of what their baseline is without PAP at all. So you might see that. We got another video.
Obstructive sleep apnea, or OSA, is a potentially life-altering and life-threatening breathing disorder that occurs during sleep. OSA causes a person's upper airway to repeatedly collapse, causing cessation of breathing or an apnea. In addition, OSA also causes inadequate breathing or a hypopnea, in addition to snoring and ultimately sleep fragmentation. Prevalence of OSA is estimated at 5% of the adult population. Approximately 18 million people suffer from sleep fragmentation, resulting in chronic daytime sleepiness. Left untreated, long-term effects of OSA include hypertension, stroke, cardiac arrhythmias, and myocardial infarction. Short-term effects include decreased quality of life, excessive daytime sleepiness, restless sleep, poor judgment and concentration, morning headaches, and irritability. Continuous positive airway pressure, or CPAP, is the most widely used treatment for OSA. CPAP is typically applied via a nasal mask. CPAP delivers the same pressure for the entire breathing cycle to generate a mechanical barrier or a pneumatic splint to prevent the collapse of the pharynx.
So the different effects, the beneficial effects that PAP can have is it can improve a person's overall sleep quality, keep them sleeping more consolidated so they're not waking up as much. If we can avoid the need for surgery, that's ideal, that's a positive. Avoid their airway from collapsing and the annoying noise of snoring so their bed partner is able to sleep better. Their AHI is reduced, their oxygen stays more consistent and hopefully at a healthy range. Both objective and subjective measures of sleepiness are reduced, and overall you could see an improvement in their overall quality of life, their ability to function, their mental capacity, their memory, all of that, and just overall their mood. There's just so many different positives to it. The other thing with it is it can reverse the mortality risk associated with having sleep apnea. You'll typically see a significant improvement in the person's hypertension and blood pressure levels once their apnea is under control as well. You'll start to see that they have that normal dipping pattern of their blood pressure again that happens at night where their blood pressure backs off when they fall asleep. You'll see that their cardiac function is improved because you no longer have that struggle to breathe, so you no longer have that change in the intrapleural pressure that's occurring when the airway is occluded, and that paradoxical motion of breathing that can happen. So cardiac output can be improved, all their cardiac profiles can be improved, and they've proven that it does improve overall, like, long-term health care claims. Like, they've studied these patients, and you know how they've done study, like, the point of, if we can keep patients out of the hospital, their overall use of insurance is reduced, thereby the cost is reduced on their health care. And they've found that when patients have PAP, if they have OSA and they're successfully treated, their health care claims do go down as well. So the three types of masks, the most common types of masks, are your full face, your nasal, and your nasal pillows. It's important that you understand all of them, because it's our job to not only be able to explain them to the patient, but also to help guide them what might work best for them. So I explained the nasal mask in that it goes over your nose. You're only breathing through your nose with this. Pros of it are the head straps tend to be quite stable, so if you tend to toss and turn a lot, it really moves with you. Cons are that you still have something on your face. Some of them are built with that forehead piece, so you can't wear your glasses, but a lot of people don't wear their glasses with this on. And then the next question you'll get is, but I always sleep through I don't know what I do when I fall asleep, or how will I know to only breathe through my nose when I'm asleep, or I think I breathe through my mouth when I'm asleep. And that's where I'll kind of go back and describe the whole pathology of OSA. When you're trying to breathe against an occluded airway, when you're essentially getting choked, of course you're going to open up your mouth to try to gasp in the air that you're not getting. So a lot of apnea patients become mouth breathers because of the nature of the disorder. With CPAP, they'll be getting the air that they need. They'll be able to breathe unobstructedly. So the need to breathe through their mouth isn't there anymore. And the other thing with it is when you open up your mouth with this type of mask, it becomes very uncomfortable with that air leak going in the nose, out the mouth. So it pretty much retrains the people to go back to breathing through their nose. And while I'm explaining all this, I'm observing them. What are they breathing through? Are they breathing through their nose or their mouth? And I'll usually point that out to them. Like, the entire time I've been running my mouth, you've been breathing through your nose, which shows me that you can breathe through your nose. If you can breathe through your nose during the day, you can breathe through your nose at night. And sometimes if they're a really hard sell, I'll even bring up, look at infants. We are born as obligate nasal breathers. That's how our body is designed. Our body is designed to breathe through our nose. That's where our natural humidification process is, and the nasal hairs or whatever to knock out. Yes, thank you. Versus we don't have that when we breathe through our mouth. Our body is designed for us to breathe through our nose, and it's through a lifetime of apnea, deviated septums, congestion, whatever, that we've gone to and reverted to breathing through our mouth. But it's really going back to our body's natural way of breathing by going with a nasal mask. And that's usually pretty convincing sell for them. I try to start with the most littlest necessary, because for the most part you'd be surprised how many people adapt right to breathing through their nose with a nasal mask. Some of them need the chin strap, not a lot of them though. I haven't used a chin strap in a long time, and I've even had some people say the chin strap made them more claustrophobic than just using a full face, because of the nature of how tight it can be on the face. So I always try to start with a nasal mask, or a nasal version, nasal mask, nasal pillows, because full face masks are larger, they're heavier on the face, and you have a lot more risk when you put a full face mask on a patient's face. say they were to lose power and the machine were to go out. With this mask, all you gotta do is open up. I mean, these masks aren't airtight, you can breathe through them, but it still can instill that sense of panic, you know. But all you gotta do is open up your mouth. With this one, you will feel the hot breath of your own breath, and that eventually will wake you up by rebreathing your own breath. The other thing is, what were to happen if someone were to vomit in this? The risk of aspiration is so much higher. You got to think of, too, look at your patient. This little person, are they going to be able to put this honkin' mask on? How's their dexterity? Are they better off with a simpler, smaller mask? Think of all of that. The full face mask is the only mask that allows the patient to breathe through their mouth. So if they're an obligate mouth breather, this is the mask you've got to go with. So for instance, Down syndrome. That population, they usually tend to breathe more through their mouth because of the nature of the different anatomical variances that you see with that disorder. I think I've only ever had one Down syndrome patient that I successfully fitted with a nasal mask. So that's how I explain this one. You know, this is the only mask that lets you breathe through your mouth, so that was the pro of it. But the con is it's a lot bigger and heavier on the face. Could take a lot more to get used to. And then nasal pillows fit just inside the nose. So the pros of this one is it's the most minimal of all the masks out there. So if you have somebody that's claustrophobic, that really likes more of a minimal contact style mask, this would be the go-to. Cons are that the straps, there's not as much to them. So if somebody moves around a lot, they have a really flat back of the head or really smooth hair, this mask can be slipping and sliding out of place a decent amount. The other thing with this is in long-term use, the inside of your nose is really sensitive skin. And so some people might complain that after prolonged use of this mask, they start to get sores on the inside of their nose. And it's one of those things that you'll get some people that's kind of a deal breaker for them. They won't use it. Or you'll get some people that are just so in love with their pillows that they'll use pillows until they get the sore, switch back to a nasal style mask for a couple days, let their nose heal, and then go back to the pillows. It's all a personal preference. But they've really come a long way with the pillows, though, as well, in that if you feel them, don't feel them with your fingers, but with gloves or whatever, or feel them through the bag, they really are so much softer now. They used to be made of a much more firmer silicone, which was more prone to causing that irritation, and they've come a long way. So some of the things that I will ask patients are you claustrophobic? Do you typically breathe through your nose or your mouth? And that can help us start guiding or steering the conversation in which way. And I will still explain all three types of masks, all pros and cons of them, just like I just explained to you, and let them ultimately make the decision because they're the ones that have to put it on every night. So I'll explain all of that, and I'll explain this is what my thought is based on the fact that you told me you are claustrophobic, that you do typically breathe through your mouth, but from what I'm observing, you're not breathing through your mouth now. This is what I would recommend. So you want to I've always found that I kind of throw patients for a loop when I let them know that I have been observing them. Like, well, I've just been talking to you for the last 5 minutes, and the entire time you've been breathing through your nose. Really? Oh, I didn't realize. Like, yeah, I was paying attention. People don't expect you to pay attention. Throw them for a loop. And so you want to use your clinical judgment and your clinical experience to better guide the patients because they're going into it fairly blind and they're relying on your expertise to choose a mask that's right for them. So when patients tell me that they can't breathe, they're mainly mouth breathers, I'll ask them, well, do you have trouble breathing through your nose? Is there something that physically prevents you from breathing through your nose, like a deviated septum, congestion, anything like that? You know, once they start saying yes to those, that's kind of pointing you more in the direction that you're not convincing them to go to a nasal mask. Physically, they need a full face mask. But you want to find a mask that the patient is comfortable with wearing. You don't fall into the habit of just getting comfortable with one specific mask. Try a bunch of them. There's so many different ones out there. But you will start using, like, once you've had success with one, like, keep going back to that one and getting really comfortable and familiar with that one. You look at me, but you will. You all will. And every tech does it. But always just switch things up. Try a new one. Because the thing with it is they're constantly coming out with new and updated things that, you know, they're listening to the feedback. These companies that create these masks, they are truly responsive to feedback from customers, from patients, from clinicians, from like what we're complaining about with the mask, and constantly revising it and always making them better. Because look at the competition out there now. If they don't, they would have been closed down years ago. But the mask can truly be a hindrance in that if a patient's not comfortable with it, once they're home with it, they just might not put it on anymore. You know, it's simple as that. They don't have somebody there saying, hey, you need to keep this mask on, you got to put this mask on every night. It's up to them once they get it home. It's their own responsibility. If they don't like it, they're not going to put it on. So use your interview techniques and your clinical judgment to try to pick a mask best suited for the patient, and think critically, in what circumstances would a certain mask be more beneficial than another? Is there anything else besides mouth breather claustrophobia that you can think of? Seasonal, so it's only certain times of the year they can't breathe through their nose. What about just anatomy? Like, just look around the room at everybody's different face. Like, your face size does not indicate your nose size. And, like, take a look at the bridge of everyone's nose. Like, you're all staring at me, but look at each other. Like, some people have very thin bridges of their nose. Some people have wider bridges of their nose. Some people have wider bases of their nose. Some people have long, narrow nostrils, or wider nostrils, or just, you know, it's all different. And so that can also kind of guide you, because certain masks are better suited for certain different anatomical variances. If I have somebody that's got, like, you know, really thin, tiny little nostrils, and it's really pushing open their nostrils just to get nasal pillows in, is that the better mask? Or if you have somebody that's got such a weak and thin bridge of their nose, are we doing them any favors by putting a mask on their nose that rests right there that could put further pressure on it? Right? Start thinking of things like that. If somebody's got, like, glorious, ginormous beard, I'm probably going to try to steer away from a full face mask as much as possible. If they've got a really bushy mustache, I'm going to try to shoot for nasal pillows, because I don't even need to deal with trying to get a mask to seal on their face. It's just going in their nostrils. So the most important factors when you're choosing a mask is that the patient is comfortable with it and that it fits the patient well. Because if it doesn't fit them well, if it's leaking all over the place, they're not going to get the therapeutic benefit or effect of wearing PAP. It's not going to work as well for them. And if they're not comfortable with it, they're not going to wear it. So one study found that patients who switched their mask initially, like, so say they were fitted with a certain type of mask and they chose to come back and switch their mask, they were at a 7-fold higher risk of abandoning PAP therapy during the following year into those who did not switch. And the major reason for them switching was because either the mask fit them poorly, or they were uncomfortable with it, or that it was causing a lot of leak issues. So you really want to try to get them right the first time to really set them up with some success right off the gate. Also, whenever possible, you want to try to start with a nasal mask or nasal pillow mask, because certain studies have also shown that patients that were fitted with a full face mask had more issues with being adherent to therapy, and were more linked to not getting the therapy that they needed to be effective, and had an increased risk of side effects. Basically, in studies comparing all the different types of masks we use, everything was always worse when a patient had a full face mask. Their average AHI was higher with a full face mask. Do you guys want to think of why? Why, if we're delivering PAP, why does it make a difference if we're wearing full face or nasal? The pressure is the pressure. About where the mask is laying and the straps we're putting on and the anatomy of what can cause. It can cause a full face mask based on the pressure on the jaw can cause a slight retrognathia, which can worsen apnea. So that's why you tend to get better effective treatment with a nasal mask or nasal pillow mask. So when you have a mask that doesn't fit well, it can hinder the effectiveness of it, cause a lot of leaks, which can cause a lot of issues in and of itself. So depending on where the leaks are going, if it's going in the eyes, it can cause dry eyes, irritation, in severe instances, conjunctivitis. But there is what's known as an intentional leak. So that's the leak that the mask manufacturers plan for, that we intend for. So that's the leak that comes out of your exhalation port on the mask. So when we say what's a typical leak, and I'll always tell you, when you open up a mask, there's that little booklet that comes in with it. And in every single one of them, there's a chart. So before you just throw those booklets out, put them in your pocket to save, to look at later. Because those masks or those booklets will not only give you some tips and tricks for that particular mask, but tells you about where your leak should be based on what pressure you're on. Because they studied what the intentional leak should be for each of the masks. Unintentional leak is the leaks that we don't plan for. So whether the patient it's an ill-fitting mask and there's air leaking from around the mask, whether they're opening up their mouth and they're wearing a nasal mask so air is leaking out of their mouth. But when we minimize the unintentional leak and get them so that they're breathing through their nose, or just get them with the right fitting mask, all their overall parameters, their arousal index, their oxygenation, their amount of REM sleep, will all improve. Let me see what this YouTube video is. Is it this? No. Well, it's this one, but tell me what's wrong with the picture already. She's not using gloves, and her fingers are all over that mask. Even when you're wearing gloves, I try not to touch the part that's going in their nose or on their face.
Mouth breathe, and as well as have many allergies. The first thing you do when fitting a full face mask is to make sure that all the straps are loose.
But the point is that you loosen all four straps, all your straps as much as possible before you try to get this on the patient. Use your quick disconnect clips whenever possible. I don't make adjustments to the mask without having flow coming through. Yeah, it's really rough on the face. I should probably find a better YouTube video. The thing with this one too is when you have a forehead piece and you're fitting the patient with a mask, the kind of the big thing that we get into the habit of is like you want like all pieces to be flush against the patient's skin. But say you get the mask on the patient's face and that forehead piece is hanging out in no man's land, but you're still getting a good seal, that is okay. Remember that. It is okay for that forehead piece to be out there. You don't need to keep stugging until it's against the skin. Okay?
That will actually release the pressure off the nasal bridge, making it a little bit more...
It's like almost as bad as me talking with my hands.
Once the pressure is added, you will connect the tubing onto the swivel, which is right here, and then you should feel pressure coming out of here.
So the point is I always show the patient where their exhalation port is, because when you don't, you'll get them calling you in there in the middle of the night. It's leaking. The mask is leaking from right here. Like, yeah, that's normal. But I also just pointed out so they know, like, this is so you're not breathing in the same thing you're breathing out. That's where your exhalation gets filtered out. Good video, right?
Ball and socket out.
Bless you. So some common issues encountered is dry nose, sometimes can lead to sore throat, nasal congestion, and runny nose. So what can happen is PAP air is seen as an irritant. Your body interprets it physiologically that it's an irritant. And so when you have an irritant entering into your nasal passages, what happens is your body will respond physiologically to try to protect the nasal mucosa, and will respond by creating more mucus and nasal secretions, which can cause the congestion and the runny nose and all of that. But it actually makes then everything worse because you're increasing your nasal resistance, right? One of the very fun reasons why you could be doing a PAP titration and you think you're all good and you're done, and you got them set, and then like 4 o'clock in the morning, all of a sudden they start snoring again, and you're like, what the hell, I thought I was done. Because it's their bodies, now it's enough time that they've been on it that it's leading to issues. Dry mouth. So dry mouth is one of those things that if a patient complains of dry mouth and they're on a nasal mask, nasal pillow or nasal mask, that's an indication that they're opening up their mouth. So they either need a chin strap or a switch to the full face. Dry mouth with a full face is normal. Maybe try increasing their humidification setting. In severe instances, the nasal irritation can cause nosebleeds. It has happened. It's just what I said. So the treatment for the nasal issues would be heated humidifier, or sometimes the physician might prescribe a nasal spray to help reduce the congestion and the irritation. It can act more as like a protective measure. If they're opening up their mouth, to add in a chin strap. There's been certain instances where I have had to use a chin strap with a full face mask because of just like how the person was breathing and how many issues I was having getting a good seal and stuff. So you do what you can. You become a MacGyver on nights to try to get things to work. But the chin strap is essentially a jock strap for your chin. It holds it all in place. It goes underneath your chin and around behind your head and just gives your chin enough of a lift so you have less of a tendency to drop it open. That's not to say that it keeps the person's mouth closed if they can't open it at all. They still can. And you still might get like the with the chin strap on, with their air fluttering out of their lips. When that happens, you grab the duct tape and you just tape over their lip. Don't do that. I did have a patient do that though. He would duct tape his mouth shut every night.
Oh my God.
He was a doctor too. Yeah. And I was like, I am not touching the tape. Whatever you want to do, you do. And he was there for a retitration, so I ended up having to bring his pressure up. He kept waking up having to add on little extra pieces of tape to seal all the cracks. It was a ridiculous night. Once in a career kind of night. Other issues would be irritation of your eyes and the skin. That can be caused from leaks from the mask, discomfort from the mask, abdominal bloating or aerophagia. That would be air swallowing if they're swallowing in it. So some of the causes of that could be that the mask isn't fitting them well, it's not cleaning them, they're not cleaning it properly, or that the pressure is set too high. So the number one cause of skin issues is improper cleaning techniques. I always revisit how they're cleaning it. If necessary, if it's a mask fit issue, I fit them with a new mask. What you can try to do is also enable the ramp feature, which is available on pretty much all machines, that drops their pressure down and will slowly incrementally bring the pressure up over a set period of time, to hope that they're asleep by the time it gets up to pressure, but also just to reduce the constant level of pressure hitting them. For aerophagia or abdominal bloating, common side effect where people could be swallowing the air. The treatment for that would just be to lower their pressure down a little bit. It's probably a side effect because they have too much pressure. And it's so important to instruct the patient on the importance of cleaning their equipment. And that's usually a conversation I start early. I might even start it on the night of their titration as we're going over everything. As I'm setting them up, like talk about, what they're kind of in for in terms of the upkeep of everything. If they have sensitive skin that's causing irritation from the mask, what you can do is, it's a product called Moleskin. It's almost like a Tegaderm type product, anything like that, where you put it on and it creates a very thin, almost like a thickness of skin barrier between the mask and the person's skin. So the mask itself isn't actually on their skin. And there is a company out there that now sells liners, CPAP liners. They're like cotton little cutouts of fabric that fit underneath certain masks. So you put that on and then you put your mask on. So the mask itself is on the cotton, and the only thing against your skin is cotton, not silicone. None of the masks are made with latex anymore because of the amount of latex allergies out there. They're all pretty much supposed to be made from silicone, but it's all silicone is not the same. So I always use this example. My sister-in-law was having a lot of irritation from a certain mask, and I went over cleaning with her. She has the cleaning machine. She was doing it all right. And then I gave her a few different masks to try, and it was always with one brand of mask that her skin was breaking out. And I came down to it. I was like, that's always this brand. These are both of those masks that keep irritating your skin are this brand. So it was this particular brand and how they must have formulated their silicone that was causing her to break out. And I always use that example because it's something we don't even think of. And I was scouring the internet and the package inserts for the ingredient list for those masks and what they're made out of, but I couldn't find the common ingredient, but it was just something in that brand silicone with that mask manufacturer that irritated her skin. Pressure relief ventilation. So that's the C-Flex on Respironics machines. It's also called EPR, or expiratory pressure relief, on the ResMed machines. And basically what it does is it backs off on the pressure at the end of exhalation so that it's a little more comfortable to breathe with. That's in that lab what we were playing with. Is 1 or 2 better, 2 or 3? And it's a newer technology that's on most machines. This video can explain it better than I can.
Respironics, the global leader in sleep therapy products and solutions, has developed a revolutionary, more comfortable treatment for OSA called C-Flex. C-Flex therapy makes it easier to exhale by providing pressure relief during active exhalation, then returning to baseline pressure before inhalation to maintain the pneumatic splint necessary to keep the airway open. C-Flex eliminates the problems patients typically encounter with CPAP pressure by providing a variable release of pressure during exhalation. This pressure relief is based on the level of patient flow and the patient-selectable C-Flex setting. Because it is variable based on expiratory flow, C-Flex provides the appropriate response for each and every breath. C-Flex makes it easier for the patient to exhale, then quickly returns to the optimal pressure for the patient to ensure that air flows freely to the lungs. In addition, C-Flex provides the patient a choice of 3 levels of pressure relief, assuring they find a level of comfort that feels best for them. C-Flex allows patients to breathe more naturally, while providing the ability for patients to easily tolerate their therapy. A tolerant patient will comply with their treatment, improve their quality of life, and eliminate the long-term risks associated with OSA.
So with C-Flex, when it first came about, we were using it on everybody. The physicians wanted us to use this new feature, and it's just to make it more comfortable, and so what's bad about it? Well, as time has gone on, they found that it sometimes can inhibit the effectiveness of therapy. So a lot of the physicians are now erring more towards the side of at least starting your titration off without it, or your desensitization trial without it, and if the patient's having trouble acclimating, then adding it on and just playing around with it to get them the most comfortable, to get them tolerating it. The other thing with this is when you have somebody bring in their machine and you're pressure checking their machine, if the C-Flex is on, it's not going to pressure check to pressure. So say their machine is set at a CPAP of 10, but their C-Flex is on, When you go to pressure check, it'll probably only pressure check at a pressure of 8 or 7. And then you're thinking like, man, this machine is starting to die. They might need a new one. Turn the C-Flex off. It'll pressure check no problem. So that's something to keep in mind too when you guys start getting more towards DME end of things and checking in on patients' machine and on their current equipment is the C-Flex on, because that's something that they can turn on and off on their own, just like the ramp feature. They have total control over that. So some adverse consequences that you might see with PAP are, it could be waking them up. And typically I'll explain this to the patients in that some of them will say in the morning, I feel like I woke up more with this mask on my face. And my counter to that is overall, you actually woke up, the overall number of times you woke up was significantly less. But you woke up more to the point that you remembered because you have this very foreign thing on your face, right? Sometimes you can go too high on pressure. You can cause a barotrauma or a pneumothorax. You can cause discomfort in their chest and a tightness feeling in their chest. The feelings of claustrophobia is real. So make sure you're very sensitive to that, with this very slowly increasing the pressure and also slowly decreasing the pressure. If you quickly drop the pressure, you're going to create that sense of panic, and even worse, I feel like, than going up on the pressure, because it feels like somebody's sucking the air out of you. Some people might feel like they're getting suffocated with it on, or they, the difficulty exhaling, because it is a constant pressure, the same pressure they're breathing in with, they're breathing out against. And so as I'm putting it on, I'll explain kind of the mechanism of how it works. This is how it feels. You're going to feel this resistance to how you exhale. That's normal. Them knowing that that's normal and it just takes a little bit of getting used to can help them with the acclimatization process. That feeling that they're getting suffocated. So when you have a patient with a really severe apnea and you put them on PAP and you got to start off low because that's how the lab protocols work, if they're continuing to have back-to-back respiratory events with the PAP on, they're going to probably attribute that feeling of suffocation not to their apnea, but the mask is doing it. This machine is suffocating me. One of the reasons why you want to start at a appropriate starting pressure, and if they're having back-to-back events, be aggressive with your titration until you at least break open their airway and get them to the point where they're not having back-to-back apneas. Because, when they wake up complaining and saying, because they're still having apneas with it on because you haven't fully titrated them, which is fine, but if they wake up saying, this thing is suffocating me, you do not want that to be one of their initial impressions of this. It doesn't bode well for the long-term compliance. And some people do complain of noise from this machine. It's fairly quiet, but the noise of either the exhalation port or just the machine itself, whatever. I never understood this one, because are you kidding me? The noise of this machine is significantly less than the noise of your snoring. But okay, let's complain about the machine. The point is as much as you might think it, I'm not going to say, are you kidding me? You're such a baby. But, all complaints are valid. One of the suggestions would be take a mouse pad or something, or a towel, and put it underneath the machine to pad, so it somewhat absorbs the noise from the machine. It's from the hard surface or whatever. Stuff like that. In terms of a lot of the different reasons patients might have be not adherent to therapy. So if they're not feeling like they're receiving a benefit to it, one of the things I'll always explain too is, so as you can see, I explain a lot. I'm huge on everything I'm going through with the patient, so these appointments can take a long time. Some of it I wait until I'm actually doing my application because I got a lot to say. And so as I'm applying, I can keep talking about it and revisiting it and stuff, and say things like, well, listen, you might not wake up tomorrow feeling like $1,000,000. Once you even get the machine home, you might not feel immediately the way you were hoping to, but that doesn't mean it's not working for you, because at this very moment, you're how sleep deprived. Like, how long, how many years has the sleep issue been going on? How severe is it? There's no way we could quantify the level of sleep deprivation that you're functioning at this moment. So how long it's going to take your body to recuperate, I don't know. We don't know. And sometimes it takes quite a while. So it could take a while for you to feel that benefit. And sometimes that benefit is slow, just like the progression of sleep apnea. You don't wake up all of a sudden and have severe sleep apnea. It's probably been an ongoing thing that's been worsening throughout the years. The same thing like this, where it might only be in hindsight that you see, wow, I am feeling better than what I did 6 months ago. I'm able to do more with my day than what I was before I was on this, that type of thing. You guys can read through these common issues. I feel like I've talked about most of them already. When the pressures get too high, if the patient's on a high pressure, we can try auto PAP instead to see if it can't back down whenever possible. It is inconvenient to use this. It is. It's inconvenient to have to pack it up. It's inconvenient to have to clean it daily and do a deep clean of it weekly. It's inconvenient to have to come to all these follow-up appointments. It truly is. But if the patient knows why they're doing it and what benefit they're receiving from it, it can make a world of difference in their ability to deal with this inconvenience. And one study I read was when a person has a disease, sometimes, like, the amount of time and money invested into the treatment and all of that could be akin to having a part-time job. So you never want to take away, like, what their role is going to be in this, or how much of an inconvenience it could be. I'm always honest with them, but I do try to soften that impact and make them realize why they're doing it, why it's so important. So claustrophobia, when you have a patient that's really bad, we always go through CPAP desensitization. We do like a mini version of that at the start of each titration night. Like, I'll explain everything, I'll fit them with a mask, let them sit with it on for a little bit. That way they're not coming in and I'm slapping all the wires on and then slapping a mask on them and saying good luck, good night. But there is what's known as called a PAP nap, where they're bringing patients in now during the day to do the desensitization process, so they have more time, and they'll usually give the patient a couple hours for these appointments, where they'll come, they'll go through the whole desensitization process, they'll let them sleep or even try to lay down and take a nap with the PAP on. They won't adjust it. It's not a titration. It's really more for those people that need this additional time, so they have this time to mentally process what they're coming in for the night of their sleep apnea test before they come in for their titration. Does that make sense? Like, just give them more time to better, so they know when they come in for their titration exactly what's ahead of them, versus hitting them with it like when they walk in the door at 9 o'clock at night. Okay, here's your PAP mask, this is what we're doing, let's get the wires on, yeah, you gotta get to bed, right? That can be like a wham bam, thank you ma'am kind of appointment, but some people need more time. Gastric distension, aerophagia, so that's air swallowing, so you can either try lowering the pressure or switching over to BiPAP. So, because sometimes with BiPAP we can naturally lower the pressure because you're using the two different pressures. Compliance is a huge issue. Only about half of the patients are consistent CPAP users, and the rest can use it intermittently with a very wide range of how much they're actually using it, with the average nightly use between 4 to 5 hours. So they're probably not using it all night, maybe putting it on in the beginning once they wake up for their first bathroom break, leaving it off. Still, something is better than nothing. But what they've found that factors long-term use is the patient's snoring history, how severe their illness is. So the more severe the AHI, the more likely they are to be compliant, whether or not they feel like they're receiving a benefit. So if they can feel they're getting a benefit from therapy, they're more likely to go through and use it and go through everything they need to go through to keep using it. There was this one old guy. He was the cutest, the sweetest dude. That was like his 4th or 5th time coming back to St. Pete's for a mask refit. You could see it on it, like he had sores from the one mask, inside of his nose was all, like, but he was just so gung-ho and positive about making PAP work for him that like you didn't want to give up on him. You wanted to keep working with him and, okay, let's try this mask, let's do this mask, because he was just so sweet about it and about how he's like, I mowed my lawn all by myself and I didn't have to stop once. I haven't been able to do that in 5 years. And it was just like, you wanted the fight with him, you know, and when they feel the benefit, they're a lot more likely to keep up that fight. The other component of it is they've done studies where a few of you had brought this up, like, well, why don't we do split nights on everybody? Get them done in one night, it's easier, save them time, save insurance money, blah, blah, blah. But what they've found is when a patient underwent a full night CPAP versus just a half night, compliance increased. It did have a noticeable impact on their compliance. So when patients are still complaining of sleepiness and they're on CPAP therapy, some things to look into is their pressure working for them? So we only get them for a night, and remember, we only have them for a night to try to find that perfect pressure. You can have a lot of night-to-night variability with your AHI. So maybe the pressure that worked for them on that night might not be working for them, be the best pressure for them over the long haul. Are they adherent to therapy? Are they, do they have anything else going on? So typically when we do a sleep study, a person can have numerous sleep disorders present, but apnea kind of trumps them all when it's looking at the results. And it's not until apnea is under control that you're better able to visualize and see that they also have a concurrent narcolepsy or hypersomnolence, some type of disorder going on that they can then be evaluated for. What medications are they on that could be also contributing to their sleepiness? There's a whole lot of things, but like the apnea kind of has to be under control first before you can really look at other avenues of why they might still be tired. So the desensitization process it takes, on a good night, a quick night, 20 minutes. Sometimes it can take upwards of 40. But what you're going to do is explain the mask to the patient, help guide them in making a decision, and then fit them with whatever mask you've chosen. So they choose a nasal mask, you go grab one and decide which size is appropriate with them, small, medium, or large. Make sure they're comfortable with it, it fits them well, and then I let them sit with it on for a while. Not only just sitting up, but also laying back, because it does feel different when you lay down with it on. I encourage them to try getting into the position you normally sleep in. So kind of adjust your experience to how you're better explaining to your patients. Like, get comfortable, move around, make sure you're comfortable in getting into whatever position you want to get into, because you can with PAP on. You're not stuck to one position. Give the patient time to acclimate to the mask, to breathing with it, and to adjust their breathing to it, to the pressure. It's important for not only the patient, but also for you. That's when I'm running back to my desk, I'm checking the leak level. Does the mask truly fit them well? Because it's one thing that it just looks like it fits them well and you don't feel leaks by putting your hands there, but to truly see what their leak level is gives you a better value of how well the mask fits them. I also will check their flow signal. When a person's doing well with PAP, their breathing pattern takes a nice steady rate and rhythm, and you can tell when you've gotten a good flow signal with them on PAP that they've truly acclimated to breathing with it on, versus if you have a very choppy pressure, or you're watching them continually open up their mouth with a nasal mask, or, you know, again, watch their body language. Are they tapping their knee and like constantly moving and fidgeting? You know, their body is telling you, their body language is telling you more than what they will, that they're probably not comfortable with it for some reason or other. So this is the time to troubleshoot those issues, because the last thing we want to do is refitting them in the middle of the night, or having them pull the mask off 15 minutes into the study and them saying, yeah, this isn't for me, because that's happened before. So we want to try to do anything that we can. Respond to the patient's concerns, to their discomfort, to any issues with mask fitting, because if you're not getting a good seal on the mask at the start of the night, I guarantee it's not one of those things. It's not like an impedance level. Oh, it'll warm up, it'll get better. It's just going to get worse. So if you're already starting out with a bad or high leak level, it's just going to get worse once they fall asleep and those muscles relax even further. So get it all troubleshooted, whatever. Figure it all out at the beginning of the night. And this is the only time that I'll typically ask leading questions. I try to ask more open-ended questions of the patients, but I've found in the number of years that I've been doing this that with PAP, sometimes it's just so new, the patients can't even verbalize their complaint or what's going on. They know they feel something is off, but they just can't put words to it. So this is the only time I'll actually ask them leading questions, such as, does it feel like it's cutting off your breath? Like each time you take a breath in, does it feel like you really have to suck in to get enough air? Because that would be an instance that your pressure is too low to start with. Like bring it up a point or two to get them at a more comfortable starting level. Typically, I'll first apply PAP with the patient sitting up. Depending on how they are, I'll actually just have them hold the mask against their face versus even doing the head straps, because them knowing that they have the control to just take it off, put it on and off, helps them better acclimate to that initial, because I just remember that feeling of when it was first put on you. Do you guys remember that, the way it took your breath away and that jarring feeling that you had? Don't ever forget that feeling, because that's what our patients have every single night. So talking them through it and being that calming tone of explaining, okay, this is what you're feeling and this is why. If you're feeling this, don't worry, you can easily take the mask off. Once the mask is fitted on them, I have them laid down with it so I can finalize the mask fit. The other thing with it too is, especially like a full face mask, even if I am slightly adjusting it when I'm sitting up, I have them tip their head back, because that mimics the flex of their neck more when they're laying down than when they're sitting up. When you're sitting up, your jaw, your chin is down. So think of now the distance from here to here. Those bottom straps are going to be a lot tighter. And then when you go to lay down, they can't even flex their neck back because it's so tight around their jaw. So I typically will have people somewhat flex their head back a little bit to get the final adjustments when they're sitting up before I have them lay down. And then you've got a more accurate kind of assessment of how the mask will fit them when they're lying down. I let them lay with it for 10-15 minutes or so, get into different positions. I'm observing their flow signal. I'm observing their body language. I might play around with the pressures ever so slightly. We're certainly not blowing them out of the water like we did in lab. Like, okay, let's see how high they can stand it. But if I start them at 5, I might get them to 6, wait about 5 minutes, turn them up to 7, depending on how they're doing, even up to 8 or something like that, and then ask them, well, okay, did you notice I played with the pressures a little bit? Okay, so that's pretty much a little sample of what we're doing tonight. I'll be slowly adjusting the pressures while you sleep to try to figure out what pressure works best for you to eliminate the snoring, eliminate the apnea, give you the overall best quality of sleep. You will be asleep while I'm adjusting those pressures, but if you wake up, you might feel that the air is more forceful than what we started. Totally normal, just a purpose of this. It's the purpose of the study. But if it's too much, like you're not going to be able to fall back asleep with that much air coming at you, just let me know and I'll lower it back down. And then the other question I'll ask is, well, did it feel more comfortable from when I first put it on you to when I just took it off? Because that'll kind of give you an idea of what our starting pressure should be. Should we start back at 4 or 5, or should I start them up at 6 or 7 based on what their comfort was during the desensitization trial? Pretty much everything I just said. Questions?